Hey, how's it going?
Good.
Yeah, let's get started here. Everyone see the PowerPoint slides? Give me a thumbs up if you can. Good. Okay, good. Okay, so I'm gonna expand this out. I guess I could go to full screen. I guess can I do that? I guess not. Anyway, I'm gonna just maybe try to get this bigger. But if you guys have specific questions, instead of trying to like unmute and interrupt, if you could just use that chat line on the right side. And what we'll do is towards the end, we'll actually go through that chat line and kind of direct those questions to the people who could probably answer them best. I've kind of prepared some questions already, and I've kind of already started some some basics, I guess, here, instead of having to go back and repeat things. So I just want to give you guys an overview of what we know so far about COVID-19. And then just really quickly, I'm not trying to step in anyone's lanes here, because I definitely have some specialists and some people who are very well known to the subjects here. So I'll just introduce them straight up, and maybe we could have them introduce themselves too. But first we have Dr. Vivek Nurkar, the chair of the Department of Tropical Medicine at Japsam UH Medical School. Hi, Vivek.
Hi there.
And Vivek, is it true that you've been working on coronavirus as well as part of your research?
No, we started working on coronaviruses very recently, but our group does work on coronavirus. We have people who work on coronaviruses. They worked on SARS coronavirus.
Gotcha. Thank you so much. And we'll definitely start fielding specific questions to you in a little bit here. And then next we have Dr. Johnny Yates. He's the chair or the chief of the Tropical Medicine Clinic, as well as he's also a geriatrician and family medicine physician by trade at Kaiser Medical Center, Honolulu Medical Center. And he's actually been involved in the care of the patient that actually has been treated there right now as well. So Johnny, you want to say hi real quick?
Yeah, hi. And just a correction, I actually have not had any sort of direct involvement with the hospitalized patients. I just want to clarify that.
But you have been kind of consulting and kind of assisting from afar. Is that correct?
Yes.
Okay. And then next we have Chico Calabero. Did I spell that right, Chico?
Not even close, but
Caballero,
yeah.
right?
Caballero, yeah.
I'm editing it right now. There we go. All right. Sorry, I look weird. Chico is actually one of the paramedic instructors at KCC. He's actually one of the head ones there, but more importantly, he's also a flight medic, also on the DMAT team. He's a senior member of the DMAT team here for disaster. And he's also getting his PhD in public health. He's going to be talking, kind of focusing questions on personal protective equipment, how to prevent spread, and kind of the first line approach that he uses when he's kind of dealing with patients or patients under investigation. And then next we have Claire here, definitely enjoying the sunset I see in the picture with her husband there. Thank you for joining us. Claire is a member of our Rotary Club of Honolulu Sunset, and she's also a family medicine physician, works with me at Straub Medical Center. She's in the urgent care clinics all across the island, from Kapolei to Kaka'ako to the one in the hospital. She also has kind of probably run a lot of tests on patients that are kind of coming into the clinic, maybe not so sick, but still need testing. And she also has quite a bit of experience working internationally in global health as well as in international medicine. So I definitely want to get her involved, get her take on things. And I'm also a physician over at Straub Medical Center in the emergency department. And luckily we haven't had any positive cases there, but we definitely are trying our best to not get any by not spread any, by the way, by using proper management and also following the guidelines of the Department of Health. So just kind of moving forward, again, I'll let Dr. Vivek kind of explain a little bit more about coronaviruses, specifically to the questions at hand, but just in general, this specific coronavirus, look, they call it coronavirus because it's a ball with a bunch of antigens on the outside of it. And it's important to actually understand that we've identified these since the 1930s, and first in humans since the 1960s. Like we mentioned earlier, SARS, MERS, these are all related coronaviruses. There's technically a total of 6 of them that have been identified. And more recently, with more technology, we've actually been able to identify them and kind of follow them a little more closely. How they manifest, we know this, obviously very similar to the common cold. Rhinorrhea is nasal congestion, as well as kind of sore throat, cough. The more concerning kind of thing about this is how quickly patients become short of breath, primarily because the coronavirus itself seems to attach more closely to the lung lining and specifically and bypass kind of the upper airway symptoms. So people say that you could rule out coronavirus if you have nasal congestion, et cetera. That's not necessarily true. It's just that more patients have more lower respiratory symptoms than upper respiratory symptoms. And also just understand that they've noticed that just because you don't have symptoms doesn't necessarily mean you can't necessarily get it. But we'll talk about that when we're kind of dispelling some of these myths in a little bit here. And because of that, because it affects the lower respiratory areas, people with underlying conditions like asthma, COPD, maybe past history of pneumonia, these things can actually cause worsening kind of their symptoms and ultimately lead to hospitalization as well. We know that coronaviruses are found worldwide. Obviously, because of the tracking that the media and the CDC and World Health Organization are doing, we're able to kind of track it more so. I'm not sure necessarily, there's talk about, hey, when it first started, I'm gonna be honest with you, I was definitely a naysayer when this first came on. I was like, hey, it's a coronavirus. We know coronaviruses spread. We know that they've caused a common cold. Let's just see. But obviously with it coming to the United States, it presenting pretty horribly in Italy, things are becoming taken a lot more seriously. And I think the concerns are there. It's just, like I said, just like the title, we're trying to dispel our fears and kind of deal with the facts and come up with a formulated logical solution to deal with it. But it incubates in about 2 to 5 days. You're still infective up to 14 days. And usually we know it's most likely droplet or direct contact transmission right now. The median age here in Hawaii, these are slides from the Department of Health, by the way, from a conference done yesterday. The median age so far has been around 54 years old. We've had a person test positive that was age 23, all the way up to age 76. I believe the 76-year-old person is the one that's hospitalized. And it seems like all of them, all 9 cases that we have, I think yesterday we had 1 positive, or today, so a total of 10, I believe. But 9 of them actually have recent travel in areas where I believe there were cases beforehand. And 5 of the cases at least have underlying comorbidities, including cardiovascular disease, hypertension, chronic lung diseases, chronic respiratory diseases, and diabetes. And there's also 1 person hospitalized, like I mentioned. Next, these are the kind of the symptoms. Obviously, with a caseload of 10 patients, it's kind of hard to really.
Something. Yeah, for me, it's the most meaningful work I've ever done in my life.
I'm sorry. Can people mute their mics, please? Thank you. Like I mentioned, everybody more or less has a cough, respiratory symptoms, and kind of the upper respiratory symptoms are kind of manifested as well. So it's something we can't necessarily use to rule out having the disease or not. We know that it came from China. It's been kind of called by our president as the China virus. Take it what you want. We call MERS the Middle Eastern Respiratory Syndrome, right? So I'm not going into the whole racism, xenophobia thing. I'm just saying that's where it came from. Moving forward, it was first notified to the World Health Organization on New Year's Eve, and they started closing the market down. There's concerns that it may have crossed from an animal to a human, which makes sense because a lot of animals do have coronaviruses spread. A lot of them actually found in dogs. There's also some myths and rumors saying that dogs can test positive for it. Yes, dogs do test positive for coronaviruses, but not specifically this one per se. And then ultimately the timeline goes, it's definitely kind of reached our kind of shores here. It may have reached Hawaii sooner. There's theories it may have reached sooner, but we will never know because we weren't able to test back then either. So just going through China, it is kind of a older age range. Again, very similar to kind of what we have here in Hawaii in the 10 patients we've seen, following along that same track of patients with previous illnesses. And then ultimately those who succumb to it ultimately have, multi-organ failure, likely from overwhelming infection, starting with respiratory symptoms. And kind of moving down the line here, just again, knowing that the elderly is one we need to kind of focus on and prevent. These are all the countries where we've found who've been able to test, I should say. I have a feeling that's probably already worldwide. And the cases of the United States, obviously they're growing pretty significantly here. as we are kind of moving forward with more testing. And I think we already just talked about this slide already. Sorry for the repeat. And we were talking about this slide as well. And testing, just wanted to let you know that currently in Straub, we actually have a pretty good delay in our test sites because we have to send them out to the mainland, to the CDC for confirmation testing. Hawaii does not have a CDC approved test site yet because there has to be a certain number of tests done in order to get that certification. Right now, it's about a 7-day turnaround time, primarily because of delays on the mainland as well because of lack of reagents. So this is kind of going up multiple levels beyond us. I still wonder why we don't send our samples over to Korea. You know, we could just have them on a flight, find a tribute to carry it there for us. But looks like our government officials don't necessarily want us to do that. But there is a global shortage with testing as well as with PPE. Next, just again, how do you get out of quarantine? This is something that Chico will probably kind of mention a little bit more so, but 3 days after symptoms or 7 days after your symptoms have passed. So, you know, so fever specifically, if it's 3 days after fever or 7 days after your last symptoms, whichever is longer is when you're supposed to stop isolation. And ultimately they're saying 14 days is kind of the time that they want you to stay, even though you may actually, you know, have less symptoms sooner than that. And then ultimately, you know, just, you know, I think just, this is the question that was posed by, I believe by Marco. Can patients actually get reinfected? And this is true. And this is probably why more healthcare providers are affected more so, because we're constantly seeing patients that are sick and we could be potentially reinfected 2, 3, 10 times over. So this is probably the biggest concern. And then just to close real quick, just know that this is a marathon. We aren't going to figure out everything now. There's going to be a lot of lessons learned. I've learned just personally myself that I need to be kind of sensitive about responding to questions. I need to realize that people listen to probably what I say differently than they would be if I was like an average Joe, I guess. So I need to kind of watch what I say sometimes. I personally have been a naysayer about this up until maybe about a week ago or so. And I just had a colleague of mine in Seattle who actually just, he's on the ventilator right now still, is an emergency physician. And I don't know if you guys saw Facebook this morning, but I just found out around midnight last night that my freshman year in college, my research advisor just died from it at the University of Washington. So it's getting serious. I'm not trying to say I'm going to overreact. I'm not trying to overreact. I'm just telling you that I'm personally going to hold back my cynicism a little bit more and definitely try to find ways to help people and try to, if people are panicked, I'm not going to turn them away and call them crazy. I'm actually going to try to work with them and tell them kind of the facts they need to know and try to work on it. So, you know, as a president of our club, I'm definitely trying my best to kind of unite our club. And I'm definitely wearing this big red End Polio Now shirt because I think that Rotary is definitely capable of dealing with polio. We're definitely capable of dealing with COVID-19, not in the same capacity, but I think we definitely have the leadership and the skills and the community outreach to go about doing this. So I guess we'll start off with our panel, if that's okay. So I'm gonna go back, switch out of this mode here, and maybe we'll go back to our speaker panel mode, if that's okay with you guys. Okay, I'll start out with Vivek. Vivek, you know, just going back with some of the questions, I guess, that I brought up via email to you. What's different about this coronavirus than the previous coronaviruses like MERS or SARS in the past? Hello, Vivek, are you still there?
I see Claire.
Hi. Oh, there we go. Hi, Paul.
I think Vivek is on the phone. Oh, sorry, he's been muted somehow.
Yeah, I'm here now. I was just talking to myself.
Sorry.
So I just want to introduce myself before I go with the question. I'm Vivek Nerurkar. I'm with the Department of Tropical Medicine, Medical Microbiology, Pharmacology here at the John Abrams School of Medicine. I'm really happy to be here, and thanks for the invitation. The question was, what is the difference between this coronavirus and the previous coronaviruses? It is different, but let me tell you something about coronaviruses in general. So you understand towards the end of it what exactly I'm meaning by that. So the coronaviruses are a large group of RNA viruses, and scientists have identified hundreds of such viruses to date. They are named corona, as James mentioned, because like a crown they have, and because their membranes are studded by spike-like proteins. These spike-like proteins are really important because they are going to be involved in vaccine preparations as well as in diagnostic assays too. They have been known to be infectious for decades, but were initially recognized for only mild illnesses such as common cold. A concern regarding the coronaviruses is that they are zoonotic. What does zoonotic mean? That means that they can spread from animals to humans, and they can become more virulent when they spread from animals to humans and start harboring in the humans. The animal source has not yet been confirmed, but in the previous 20 years, there have been 2 coronavirus outbreaks arising from bat to human transmission that infected thousands of people. So the severe acute respiratory syndrome, or what SARS, which emerged in 2002, and the Middle East respiratory syndrome, or the MERS, what we call, was first reported in 2012. And both SARS and MERS had a higher mortality rate than the COVID-19, but the spread from human to human transmission was very, very slow. So the first question to be asked about that, what are the difference? So the researchers have found that the SARS coronavirus 2 has spikes which are 10 to 20 times more likely to bind to the receptor on the human cells. This receptor is called ACE2 receptor. And then this spike from the SARS virus from 2002 were much less as compared to the SARS, the coronavirus 2. And this may enable the SARS coronavirus to spread more easily from person to person than the earlier virus. So the virulent part of the virus for this particular virus as compared to the previous viruses is that the spikes which it has on its crown, which are 10 to 20 times more. Does that make any sense?
Mm-hmm.
Hello?
Yep. Hello.
Yeah, I'm here.
Sense.
James? Yeah.
Yeah, I'm here. Sorry, I had to unmute myself. Sorry. Okay. I guess the next question I had is for Johnny, I guess. Some of the questions that were kind of brought up about, like, I guess we kind of mentioned some of them briefly, but just in your kind of understanding in terms of transmission of the disease, like what are some things that we need to look out for specifically? Obviously, I had a list of kind of all the symptoms there. What would you say would be more common, would be kind of more concerning? Like just even reiterating some of the things that were kind of mentioned in the media in the past as well.
Sure. So again, I'm Johnny Yates. I'm a family physician with Kaiser. I'm also the director for our travel medicine and clinical tropical medicine service. And I work in the outpatient arena. And I also happen to be away when the patient got hospitalized at our institution. So I haven't been directly involved with his care, but I've certainly been in touch with my colleagues who have. So in terms of symptoms and spread, James kind of, like you had mentioned in the slides, fever, cough, which is oftentimes described as dry, shortness of breath, are kind of the primary symptoms. And then certainly a lot of people report fatigue, muscle soreness, sore throat. And as far as spread goes, it's mainly through droplet spread. And what I'll try to do is I'll try to mention a few things that may seem a bit confusing because of what you hear in the media. So, or even just reading sometimes the medical literature. So droplet spread is the main source of transmission for this COVID-19. And so that's primarily through people coughing, sneezing, or even, if you're really close to someone and they're talking in your face. There's also contact with any sort of contact with mucous membrane. So that's why you hear the rules about not touching your eyes or your face and your mouth and nose, because the viruses can persist on inanimate surfaces for a while. So just to kind of clarify a couple of things, you may have heard about the possibility of aerosol spread, and you might even see headlines talking about the virus is viable for 3 hours when it's in the aerosol form. Well, that's actually based on a study where they actually aerosolized the virus, And really the only risk for most people, or that's really a negligible risk for most people, except in the healthcare setting where you might be intubating somebody or doing some type of respiratory procedure or even CPR. Those are situations where the virus might get aerosolized. So that's really not a main concern for most people. There's also reports about viral RNA being found in stool. So that means that they're proteins from the virus that are detectable in stool. We don't know yet, though, is it possible to transmit through stool the COVID infection or not. And so again, just droplets are the main transmission source. As far as, what were the other questions you had about spread and then about symptoms we talked about? Oh, one thing about symptoms though. So certainly, when you look at the broad spectrum of illness, it turns out that about 80% of people who are infected will have mild or minimally symptomatic illness. 15% will have severe illness, and then 5% will be critically ill. And as James had mentioned, the severe illness is really skewed towards older people and people with chronic underlying medical conditions. Symptomatic infections in children appear to be uncommon, but we really don't know the spectrum of illness. It's one of those things that we'll kind of eventually know as we get over this, and as serological studies, blood tests and checking for antibodies and things. In the end, we'll probably recognize that there's a significant percentage of people who are asymptomatic. And you even hear about that in the news, for instance, about basketball players that were tested. A lot of them who were positive tended to be asymptomatic. So we'll kind of learn more about that in the future. But in general, 80% have a mild illness, 15% severe, 5% critical. It is true that for those who have illness severe enough to be hospitalized, that what can be seen is that they can suddenly seriously deteriorate after about 5, 6, 7 days of illness. And so that's one of the concerns. And the main complication is what's called the ARDS, or acute respiratory distress syndrome. And that's for folks who have that condition. Those are the ones that are seriously ill, typically need to be intubated and put on a ventilator in the intensive care unit. I think, one other thing, clarification that I wanted to make, because this is actually kind of sometimes a bit confusing, is when people talk about the incubation period, like how long, from the time of exposure will someone get sick. The median, meaning half of the people who are infected, will actually become symptomatic in about 4 or 5 days. And it turns out that based on recent data with a large number of COVID-19 positive patients, it turns out that almost 98% will develop symptoms within like 11.5 days, okay? So what that means is, yes, there's the possibility that some people may develop symptoms after, the 14 days that you hear about, incubation period you hear about in the news, but it's pretty uncommon. So 98% of people have symptoms within the first 11 to 12 days. So that's one thing too, that's kind of, you might hear in the news 14 days, 12 days, 14 days, and then you might hear other news reports saying, well, no, it can, the incubation period can be longer, but 98% of people who develop symptoms will develop those symptoms within the first 11 to 12 days. I'll stop there to see if there are any other questions or anything else, James.
Hey, Johnny, I think Arjun Ariel has a good question. Arjun, are you there? Maybe unmute yourself and you could ask the question yourself, if that's okay, Arjun?
Sure. Yeah, I have my question on the side, actually, on the text. So I'm not sure if there is a scientific reason, but it seems in general that people who are more close to nature, for example, those from so-called underdeveloped or poor countries such as Nepal, seems less affected compared to those who are in highly developed city settings. For example, in Nepal, like there are thousands of people coming from and going to China, didn't stop even after it began. But there has been only one case, and that person is fine now. And similarly, you can name like other countries, India, Cambodia, Vietnam, the problem they have seems less severe compared to the problems we have in the US or Europe and on many other developed countries. Is there any insight on this, or is it too early to make any conclusion?
This is Johnny. I'll try to answer that. And namaste. I lived in Kathmandu for 1.5 years, so nice to see you. And exactly, I miss kind of like just being a bit of a germaphobe. I'm in the wrong profession, but that's what I loved about living in Nepal, is that you could greet people without shaking hands. But you know what? To answer your question, part of that is undoubtedly lack of testing. Okay, so in terms of some of these countries that have low numbers, so that's part of it too. It certainly is true that if you have people that are living in more densely populated settings, then you're more likely to have transmission. I'm kind of hearing an echo.
Yeah, me too.
Okay. But so that's part of it too. Now, if you're talking about rural parts of, for instance, let's say comparing San Francisco or New York City or Seattle to places like rural parts of the US, like Wyoming, certainly because you have less population density, there's less likely to be spread. But I think the main reason for the limited number of cases in parts of South Asia and Southeast Asia is largely related to the lack of testing at this time.
Okay, great. Just real quick, Rich Ziegler, I'm not sure if your hand is up on this thing because of you have a question or not. Just wanted to see. I saw that your hand was up earlier. Rich, thanks for joining us. Do you happen to have a question for Johnny by chance?
Yeah, can you hear me, James?
Yes, that's Rich. Thank you.
Okay, the thing that obviously getting ahead of the contacts between other people is critical, and testing the people who are positive, it is also crucial. And okay, Korea did such a good job, and I'm sure, and Singapore did. They got the basic question is why aren't there approved test kits across the board? What I've heard was South Korea was using test kits that our people didn't think were usable, and had them available, and therefore, because they were not the approved test kits, we didn't have the number of test kits that we might have been able to use earlier. Make sense?
I could just comment a little bit on the testing. So the World Health Organization approved a kit in Germany, which I believe was also being used in South Korea. Can I be here? Are people hearing me?
Yes.
Okay. And when the initial testing rolled out here in end of January, everything went through the CDC, and they had put together a test that was manufactured in the US because they wanted to ensure that there was good sensitivity to the testing. And it turned out to be a faulty test. So then we were back to square one. And then because of the need for more quick turnaround, the state departments of health started to do testing, and that rolled out through February, but there were still incredibly low volumes of testing being done until the FDA approved commercial lab testing. And March 13th is when in Hawaii we started to get those tests to be able to be done. The whole concept and concerns around testing is that for most people, this is a mild illness, just as a cold would be a mild illness. So we want to be able to test those who are going to be hospitalized or who may have more severe symptoms. So at this point, the testing is still restricted, and it's related to lack of the ability, like in South Korea, to test thousands of people a day. So the tests, I think, in Hawaii so far are in the order of, we're going to, in the next week, because the March 13th, Friday, was when the testing started to be a little broadened, we are going to see a huge uptake in the number of cases in Hawaii, as we have in the US. But that does not reflect that all of a sudden there's way more virus out there. What it reflects is that there are actually more testing being done.
Yeah.
I think the most important part of the testing is what we call surveillance, because we're interested, is this being imported into Hawaii from our travelers, which the cases to date have been, or is this a community-based spread that we're starting to see, as they've seen in New York and Washington state? And the surveillance testing is they're actually taking samples in certain designated offices where they have been collecting respiratory samples, and they're going back and testing those for COVID-19. And that's going to help us understand better whether it's being transmitted in our communities. But the testing to get the turnaround, for example, the March 13th tests on Friday, the turnaround is 5 to 7 days. So it's really impacting people because they're sitting around in quarantine waiting to find out if they're positive for corona or not. So that even economically, that has a big impact. I hope that helped a little bit.
Yes, ma'am.
Hey, since we're going on the topic still of testing, Ron Margolis from Kauai actually has a good question. He's asked me to answer it over the air. It says here, he says, I understand here on Kauai, between 3 hospitals, we have a total of 6 ventilators. How many are on Oahu, and are plans in place to increase the supply? I'm gonna just let you know, Ron, there is a plan actually for us to actually utilize outpatient surgical centers. A lot of the, definitely with Straub was the first to do this. Queens initially mentioned taking all their in-hospital surgical cases to the outpatient centers, and then they decided, hey, we need to stop that too. So they're actually reserving those outpatient surgical centers, ventilators. You may see them on Oahu, these orthopedic centers. They have one over in Restaurant Row. You know, these, it's kind of crazy, but they are out there, and we have a decent supply. I don't know the exact number. The military also, up at Tripler, there's definitely a huge amounts of operating room equipment that are there for exactly for this. You know, there's talk about setting up tents and whatnot. So I think we're ready in terms of supply. Also, the critically ill from Kauai, actually, definitely from Wilcox Hospital, are transported over to Straub and also to Oahu because we have the critical care physicians. There's even talk about sending critical care physicians. Some of these pulmonologists, some of these retired physicians that have expertise are actually coming out of the woodwork for good reason to then go, maybe even send out some of these outer islands to help instead of possibly infecting more people by transporting them across islands for intensive care. And the other question we have here is when local labs like diagnostic labs do the tests, do they have to send them to the mainland for analysis? I think Claire answered that. And the question is yes. And the reason why is that there has to be, I don't know exact number. Chris Whalen, he is part of diagnostic labs. He was going to give us a talk, but I think he had to cancel due to increased workload. But I believe what I was told through the Department of Health channels is that there has to be a certain number of tests done for us to certify as a specific CDC lab. So if you go to places like Cleveland Clinic, Mayo Clinic, Los Angeles, University of Washington, they have certified labs primarily because they have the sheer number of volume that they've had to get that N number, you know, that medium number to actually say you have evidence enough to actually say this test is legit. So they have to run the test here, and then they have to run the test again at the CDC lab for quality control purposes. And this was the reason why that they say that the Korean test wasn't valid because it didn't have that quality control. But you know, in a way, it's in a crisis like this, I personally think that sometimes you just have to run with what you have and use that data. And it's unfortunate because we can't, even if our test is negative, we can't say it's negative until the lab in Texas or whatever says it is. So it's kind of unfortunate. But that's the current scenario right now.
Similarly with positive tests, about a 90% sensitivity. So there are those who will test negative even though they have the illness. However, the viral load, so the sicker you are, the more likely it is to be positive. And that's why these asymptomatic people should not be tested, because it's going to be a negative test and it's going to be a waste of a test in this time where we are experiencing shortages. The other big shortage is with masks. And in one of the states, I can't remember which one, they've suspended testing because the healthcare providers have run out of masks. And until they get their supply of masks, they're not doing any more tests. So we have to be very judicious with who we test, because every time you test someone, you have to use protective equipment. And with the shortage of masks, that's another reason that tests might not be done on those who really need it.
Okay, great. And just to clarify Arjun's question, yes, you can't, the sample is actually from a nasal swab or an oropharyngeal swab. So from the back of the throat or from the nose. It is not from blood. There isn't actually a positive test yet. We've come from blood. I think it's probably best that way. The concerns also that are out there that I've noticed is that people aren't testing properly. They aren't going all the way to the back of the nose to actually check, or they're kind of just dabbling in the front or just doing kind of along the side. So unfortunately, a lot of the test samples that we've tested because of user error or whatnot, or mislabeling, have been thrown away. I've personally had half of my cases tests that I've had sent mysteriously just kind of come up lost somewhere. And it's really frustrating on my end. And I'm not talking about bureaucracy. I'm just talking about the simple kind of, lab technique, I guess, to make these things happen. And unfortunately, we're in a scenario right now where maybe panic, maybe other things are going on, but for some reason, things aren't getting done. And it's frustrating on my end. But I think once we get this set up here, once diagnostic labs, once clinical labs of Hawaii, we have technically we have 3 centers here for testing. We have diagnostic labs, we have clinical labs of Hawaii, and we also have the Department of Health. And all 3 are going to be hopefully soon certified, and then we'll get a lot more testing done. Another question that just popped up is, if I don't have symptoms and I've actually shaken hands with somebody who actually did test positive, why are they denying me my test? Was the question that I got. This was not from here. This was from an earlier question on Facebook, actually. Johnny or Claire, one of you two, somebody mind answering that?
Yeah,
So,
I'm sorry. I'll let you take that then, Claire.
so the criteria for testing does include people who've been in close contact with someone who's tested positive. So that would be someone who would be flagged to be tested. So I can't answer why that was not done. And close contact is that you're within 6 feet of someone for about 10 minutes. If they obviously cough or sneeze on you, that is another criteria. If someone is COVID positive tested, they should be, the close contacts are tested.
And I'm going to just speak on behalf of being in the emergency department. We do get a lot of people trying to flood our emergency department right now for testing. We set up a little tent outside. I think what probably this scenario happened, I can't speak on specifically what happened with this person, but we've turned away people, obviously a lot in the emergency department for testing. And the reason why is that the in-hospital tests are there for people that are symptomatic and sick. There are outpatient testing centers. There's a tent outside across the street from the police station right next to Straub. There are, these drive-through centers in Kapolei, up I think Pearl City.
If I could speak to that, I should clarify. You have to have symptoms to be tested. So if someone is asymptomatic, that is a wasted test. So as people with close contact who have symptoms, they are the priorities for testing. And the drive-through testing centers across Oahu, I can't speak for the other islands, you have to have a physician's order to get that. So for Straub, you need to either present yourself to the respiratory clinic that's now set up on King Street, or to one of the urgent cares, or you phone your doctor because they're trying to keep you out of the office. They put in the order for your testing and you can drive through and get tested. They call you and say, come now, and then you get tested at one of the drive-through centers. The same as with Queens. With Queens, they have a hotline that you call, and then there's a nurse that triages, going through the appropriate questions, and if it's considered a positive screen, then an order goes in and you go to the island urgent care. But no one does walk-ins in terms of, except the Queens do not do walk-ins at their urgent care for testing. The Straub's clinic has a respiratory clinic where you will be seen, evaluated, and tested as appropriate, as will the urgent cares as well. I'm not sure what's happening at Kaiser.
Hey, Johnny, would you mind closing the loop on what's going on at Kaiser? The process is there?
Yeah, and just another comment though. I mean, to answer that Facebook question, really in an ideal world, if we had enough testing capability and enough PPEs, then yeah, we could offer everybody to be tested. But the reality is, one, there's limited testing capability to begin with, so we have to prioritize. And then number two, you have to realize that people who are performing the tests, they should actually also be using personal protective equipment, right? Because if you're testing someone that may have infection, then you need to actually wear personal protective equipment. And that's in short supply as well. So that's yet another reason why we really have to limit it. But in an ideal situation, if there were no limitations in terms of testing and PPEs, then it would be nice if everyone could get tested, because then, yeah, theoretically, then you might be able to get, if people then would comply with quarantine and isolation, you know, you might be able to flatten that epidemiological curve. As far as Kaiser goes, so it depends on which arena. So certainly most of our testing goes through the Department of Health, and a lot of the testing requests are based on the criteria put forth by the Department of Health. Our lab actually hopes to get testing. We actually had an agreement or a tentative agreement with a research lab in Utah that we send a lot of our specialized tests to. Unfortunately, they got so swamped and overwhelmed and started to have issues with the reagents and things like that, that they couldn't fulfill that agreement. But we're actually hoping to get testing available at Kaiser at some point in the near future. But currently, at least for the hospitalized patients, they go through the Department of Health. Now, there are certain situations where some of our patients actually get testing done at commercial labs. So for instance, patients at the nursing and rehabilitation facilities, because those facilities actually use the private labs for all of their laboratory work. So if there's a Kaiser patient that's in a skilled nursing facility or anything like that, then that would actually be done through the commercial lab.
Okay, I think Del Green, you had a question. Would you mind just kind of speaking to the group?
Yeah, I did have a question. Can you hear me? Okay.
Yes.
Okay, good. So my question is, I'm seeing a lot of communication about staying at home and what have you. What is the best practice for our community at this point in time? Is it to stay at home? Because I was thinking that unless everyone's staying at home during the same 14, 15 day, whatever period of time, what good does that do for any particular organization?
Well, if I can take that question quickly, just to give a brief idea about that, you know, having to stay at home and having a social distancing is something very critical if you want to get the infection level down in the community. Currently, the infection level that we see in Italy or Spain are really high. And the reason is that people did not practice that thing, even though they were told. Now they have to have actually military come down on the road and get people out of the road for next 15 to 20 days or maybe a month. We don't want to do that. We have resources, we should use them. And this is the perfect chart which we are seeing right now. The red one is the without protective measures. And you see the dotted line, which is the healthcare capacity, or what do we have in Hawaii or anywhere around the world. So if you have a red curve, that means there is no protection and everybody is going around and visiting everybody else and passing on the infection. You are soon going to have a very peak of infections in the community, and you are going to overwhelm the healthcare system. We don't want that. So by doing this, what we are doing now, starting from tomorrow, as what the mayor has said, if we stay at home and try to make sure that we do not pass on this virus from one person to another person, we will try to keep down the infection in the community at a minimal. Hopefully that will save our healthcare system, because once the healthcare system gets overwhelmed, you can have riots on the street because everybody wants to get a ventilator, everybody wants to get in the emergency room. There is no that much space in the emergency room. So I think it's very important that we do follow of having a social distancing and stay at home for 15 days or 21 days to make sure that the spread of the virus is decreased.
It's off. I have a question too. I mean, what good is it that we are doing that, but yet we are still allowing visitors to come into the
Right.
island? And then
Right.
even after we've incubated ourselves in that 14 days, who's to say that we're not infected and they had infected the people that they had come into contact with, and so that 2 weeks is just down the drain, and it's just a cycle.
Right. No, I think you're absolutely right. And if you looked at the governor's orders as well as the mayor's orders coming out in the last 4 days, we are Hawaii is a visitor industry, our main industry in here. The governor was bold enough to say that we are going to stop visitors coming in for the next 30 days. Not sure how he's going to exactly do that, but currently the planes coming to Hawaii have also been reduced. So we are going to see the reduced number of visitors coming into the state of Hawaii. I thought that this morning the mayor has said and the governor has said that they are going to screen people at the points of entry. I don't know exactly what it means. How are they going to screen it? Of course, they're not going to be testing everybody. We're hoping that they'll be a little bit more than just looking at the temperatures. So I think there are all of these things coming up, and hopefully, if we follow, and even if we can get this spread of infection down by 20% or so, we will be in a very good shape come 3 weeks from now.
Thank you.
I have a question.
Yes.
Paul Moreau's here. So I don't know, this is for clarification really. And this is maybe dated information, or I heard or read somewhere that the average intubation time for patients with COVID in China was 4 weeks. Does anyone have any up-to-date information for those who, I guess it must be survivors, but that's a long intubation time, not incubation, intubated time, intubated in the ICU. That's a huge, you'd have to be trached to get that long. Does anyone know of the ICU experience?
Hey Paul, I'm actually in quite a bit close contact with critical care doctors in Seattle and in New York. And yeah, that's the true part of it right now. The patients that are intubated actually in Kirkland, Washington, Evergreen Hospital as well at the University of Washington, they definitely, the ARDS, the acute respiratory distress syndrome that they're seeing is actually overwhelming. And it's unfortunate, but it's not specifically that COVID-19 cases are that long. It's just that once you get to that level of acute respiratory distress, it does last that long. And you have all these different methods. You have people that are on these like rotating kind of beds that kind of help with that. There's like things that massage the lungs that kind of hopefully get some of that gunk out. There's all these different methods, but yeah, I don't know specifically, but I think you're right. In comparison to other respiratory viral infections, this is probably the longest and worst that they've seen, at least in our generation here. Who knows what would have been if we had the technology back in 1919.
But is that exacerbated because of the underlying comorbidities? I mean, it's the uniquely vulnerable population that's getting zapped that hard already has some underlying respiratory challenge.
Next, I just wanted to touch some questions on specifically with Chico. I know you've been waiting a long time, Chico, to get on. Appreciate you being here. Just kind of from your experiences, I know that I'm not sure if you've had any direct contact with COVID-19 patients per se, but obviously the challenges are there. Definitely, when someone's really sick, you guys are going into the patient's homes, transporting them in your ambulances or potentially even transporting them by air across islands. What are some challenges that you see? And if just briefly, if you can just kind of go over the different types of masks, maybe the kind of the types of PPE that we have, this droplet versus airborne precaution, et cetera, and kind of, what can we do as patients what can we do as just people kind of walking around shopping? Do I need to put on an N95 respirator when I go to Costco tomorrow? Like, what should I do?
Yeah, thanks, James. Yeah, so first of all, I'm an assistant professor at KCC. I teach in the paramedic programs. But yeah, I'm still an active provider. I work for the 911 ambulance, city and county, Honolulu. I also work on the private ambulance, AMR. So I do a lot of those interfacility transfers and responses. So yeah, we've been seeing a lot of cases. In fact, this past week when I worked, I did 3 potential COVID transfers. One directly from the airport, someone flew in from New York who boarded, who thought she was just hungover. By the time they landed, they had fever, cough, just feeling weak, myalgia. So, highly susceptible, so we are seeing them. We typically use a standard approach to all our patients regardless. We've been stepping up that approach, obviously. So one of the things that they are recommending for us is, goggles or eye protection, respiratory protection, obviously gloves, and some type of barrier device like a gown or something of that nature. So depending upon our calls, we're going to get something like, these safety goggles, regular safety goggles, or if you see a higher percentage of droplet spread, something a little more durable, something that has full protection around. Respiratory protection wise, we're all using N95 masks, which are the hottest commodity item next to toilet paper. So from last week till this week, we're literally being issued an N95 mask, and we are being, 1-for-1 type of reissuance. We just saw a memo today or yesterday that came out that said we may have to keep utilizing the same N95 mask throughout the day unless you have issues with the N95 mask, difficulty breathing, it gets soiled, of that nature. In terms of what can we do to protect ourselves, the CDC is basically saying social distancing in the public, wash your hands with soap and water for at least 20 seconds, not hot water, but lukewarm water, so that we are getting all our pores, getting our hands completely cleaned. If you can't access soap and water, obviously some type of hand sanitizer that has at least 60 to 70% minimum alcohol content. If you can't, but as soon as you have the ability to use soap and water, that seems to be the best deterrent. In the ambulance, we have close contact, and in some of the emergency rooms, because of just the sheer number of patients, you have a lot of close contacts. Everyone should be wearing an N95 mask who's working as a provider, and we should have some type of ventilation issues. So whether it's a negative pressure room for your patients, in the ambulance, we're using our vents, our exhaust vents, and air conditioners on full blast while leaving front windows open to create sort of kind of a vortex to sort of kind of increase airflow. And the bottom line in confined spaces is about air movement, getting as much air movement in there to dilute the amount of bacteria that may be, that virus that may be floating around. After all of our patient contacts and scenes, we're wiping everything down. We have these different disinfectants that have been approved for use on the ambulance to just wipe everything down. And it's a little more detailed where we soak everything, let it air dry, so make sure that it has full contact. We're not just spraying and then wiping right away. We're letting a lot of this stuff air dry. And some of the things that, as providers, we forget to do is to decontaminate your own equipment. You see a patient, you did your assessments, wipe your stuff down on a regular basis, or even better, if you can, if your facility can, get some disposable equipment. Things like, blood pressure cuffs and stethoscopes of that nature. Personally, we want to make sure that you're, as providers, taking care of ourselves. So doing little things like checking your temperature every morning using some type of thermometer, whether it's a oral thermometer or another hot market ticket are these laser non-contact thermometers. Those things you can't even get anymore. I was able to get a couple of them. But these are some of the precautions that we're taking. in terms of droplet versus airborne exposures, you know, when you have an issue with a patient who is actively coughing, those are the precautions we're most concerned about. So those you want to make sure you're wearing the most appropriate PPE. So once again, goggles, eye protection, N95 mask, and maybe even a gown, a disposable gown. I just saw something on the CDC website that said if you're using a reusable gown, make sure that it's, you know, washed at the end of the shift or put into the general linen services so that they can launder them appropriately. What other question you had, James? I'm sorry. Oh, public. So do I have to walk around Costco with an N95 mask? Probably not. The best thing to do is just protect yourself. If you're coughing, you have any signs, stay home, isolate yourself, stay home. If you are going to be in a public area, you know, you want to take that extra layer of protection. Some type of, you know, surgical mask is usually acceptable. What you're doing is trying to keep other people's viruses from being exposed to you. When we wear N95 masks, we're trying to keep our stuff isolated and not spread. So, you know, in general public, a regular simple face mask, a dust mask is sufficient if you're going to walk around in public. But if you're going to be working close contact with our patients, then you should be using the isolation precautions. So dust mask, N95 mask, goggles, gowns, that stuff.
Okay. Great, Chico. Hey, just wanted to, we have some questions. We have a question from Marco. Marco, are you online? Would you be willing to ask your question?
Yes, can you hear me?
Yes.
Yes.
Okay, so my question was, what if the virus is been around longer and the Chinese only came out like recently when it became out of control? Then that would mean that maybe a certain percentage of the world population is already been infected.
Hey, Vivek, would you mind, would you have anything to be able to answer that question by chance?
You know, I didn't hear the question very clearly. What was the question exactly?
James, you have the question.
Yeah. Hey, sorry, Mark. I just want to give you a chance to repeat it, but that's okay. Hey, Vivek, what are the chances that potentially the world is already infected with this? It's just that we're so behind the curve on tracking it and testing it that you know, is there a chance that 20 to 50% of the world population could already be infected?
Well, I think I can only tell you from my experience in here and what experience we had in the past for SARS coronaviruses. No, this particular virus is a new virus. So as we see the infection is going on, now, I don't know, the last thing which we heard was around 200,000 people have been infected all around the world. Now, I would say that is a very low ball number. You can probably easily multiply that by 5 or 10, and that many people are already been getting infected, are already infected or getting infected now. So no, it's not that this virus has been around for the last 20 years. This is a new virus. When research has been done in the laboratory setting, and they tried to use this virus to see whether can this virus be neutralized by serum samples from previous viral infections. No, they were not able to do that. That only means that we are dealing with a brand new virus in here, and it was not there before. Yeah, it was not there before in the human population.
Hey, I think the question that Marco was saying specifically was maybe even in the last few months, could this virus have already spread that quickly to you know, just this new virus? Could it have already spread that quickly in the last few months since December already? And we're just so behind the curve in tracking it and testing it that is that a possibility? Is that something that coronaviruses could spread that quickly around the world that fast?
This particular coronavirus can spread very fast. So there is no doubts about that. Now, just from looking at Hawaii's experience and what we heard from the previous speaker in here, that since if you look from last week to a couple of hours ago, we have more than doubled the cases in Hawaii. Now, does that mean that we are having more virus in here now? I don't think so. I think the virus was already there. We have more testing going on now. More testing we are going to find more viruses around in here. So I don't think that we have less number of viruses. There is a virus spread going around. We just don't know, and we had to really have a large scale testing going on too. Of course, there's a debate in the community whether we only test really people who are getting sick and coming to the hospital, as opposed to having a surveillance going on. Any kind of infectious disease outbreaks later on, we always have sentinel people too. So I think the short answer to your question is that the virus is here currently in Hawaii. Just because we had 26, that doesn't mean that many only cases. You will see more cases coming up in the next couple of weeks.
Okay, great. Thank you, Vivek. Another question we had, maybe you could answer this as well, or maybe someone else could too, but reinfection, is it possible, and co-infection, I guess those two different words, right? So right now we're using this influenza test first, and if you're negative for influenza, then we'll move forward with coronavirus testing. What are your thoughts on, first of all, on co-infection with influenza and coronavirus, which could more or less kind of mess up our current system we have right now?
So just to quickly take that question, and of course there are other experts in the room here too. But for co-infection, yes, it is possible. There is already published papers on that now. For co-infection with other viruses, specifically influenza, which you said just now. Now, reinfection is a possibility, and there are several data coming out from very recent papers saying that even in China also, as well as now in other parts of Europe, that they have seen reinfection in the same patient. We know that based upon the previous SARS coronaviruses too. So reinfection is a possibility which should not be ruled out. In short, I want to say that it is not a lifelong immunity.
Thank you, Vivek. And I guess in just to kind of touch base, I'm assuming obviously the reason why healthcare workers are more at risk, obviously, is because they're in close contact, specifically with people that are sick. But I guess the other concern could be that they become reinfected as well. That's a big concern, right?
Yeah.
I just wanted to comment about masks and personal protection for people. When you arrive at the doctor's office nowadays, at least at Straub, you're immediately screened, and if you have respiratory symptoms, you're given a surgical mask. And the reason is, it's a droplet spread, it's not an aerosolized spread. That's different than what the EMS experience, because they're doing things like intubations and other close contact events. So they need higher levels of protection. But for an individual who does not have illness and is going out in the community, there's been evidence that you wearing a surgical mask to try and protect yourself actually may increase your risk because they're a bit uncomfortable. People touch them, they fiddle with them, and they're actually potentially picked up the virus and are actually self-inoculating themselves. So the current recommendation is if you're sick, you've got cough, fever, you stay home and contact your doctor for instructions. They'll go through a screening with you to see if you need to be tested for COVID. And then the second part of that is that those individuals definitely need to be wearing a mask, even in the home, to protect other individuals from picking up what they've got. But people who are not symptomatic and not at risk should not be actually using the masks because we really need to save them for our healthcare teams so that they're protected and able to continue in the workforce in these days of shortages. And in fact, I would propose that people who have stockpiled masks at home might want to consider donating them to the hospitals and other high-risk centers, offices.
Yeah, I agree completely with what you're saying. If someone does have symptoms, they should absolutely stay home. a lot of patients that do put on these surgical masks to walk in public are not used to wearing a surgical mask. So yes, they do put their hands to the face, and there's a chance that they can actually, cause themselves an infection. But there are that group of individuals that worried well, where they have to go out. They're not staying in. They want to go out. They want to take precautions. And so if they want to, we're telling them, don't buy N95 masks. You don't need to. You can't get them anyway.
That's right.
If you want to, put on a dust mask, put on a surgical mask, whatever you can find. There's some commercials where women are using bra cups to sort of kind of protect themselves. People are coming up with a lot of different things right now, but those are for the really worried well. But if you're sick, any type of symptoms, they should just stay home. Also, social distancing, obviously. They're saying that the droplets, that 6 foot is because with a typical cough or sneeze, the droplets go anywhere from 5 to 8 feet. So they're recommending at least 6 feet distance.
I also wanted just to touch base on, we're a state of travel. And so there are people who are coming back from different places, et cetera, even now. And so in terms of quarantining yourself for 14 days, it depends on where you have been in terms of the risk in that country. So basically all of Europe now, including Great Britain and Ireland, Iran, and China, and South Korea are considered level 3, which means you should be quarantining for 14 days. And it is a global pandemic. So I even think that, if you're coming back from New York or Washington, there's high risk there too. It's not at the level of Italy that has 40,000 cases, but it would be important to check the CDC website to see what the recommendation is. Hawaii has a new, the health unit has an excellent new website that you can get up-to-date information and lots of information. I just want to share that. It's called www.hawaii, small letters, COVID, capital COVID-19.com. It's www.hawaiicovid19.com. It's an excellent source of lots and lots of information. In quarantine, people are to take their temperatures twice a day, and if they get symptoms, then they phone their healthcare provider and get tested.
All right, any other questions? I know it's 7:43, so we're kind of a little past time. I know that there are a lot of Rotary clubs I think every single Rotary club has been canceled, I believe, on the island. Correct me if I'm wrong, and I think
if I can say quickly some things for all of us here, the Rotarians as well as their friends and families. One thing you need to know that this is the month of March and this is a spring break all over the country. Many universities are off for one week. Some of our children are in those universities and either they are told to go back home for the entire semester now, or they're coming back home for only 1 week. Make sure that they are in quarantine and you are in quarantine, both too. If you are working, then please make sure that you tell your employer that you are working, you have your son or daughter or whoever the person is back home and they came from Washington or New York or any of these places where they have a high incidence of COVID-19. So please stay indoors and quarantine yourself. And I just like what I mentioned earlier, take your temperatures to make sure that you are not sick. Thank you.
Thank you, Vivek. Johnny, anything else to add?
I think when we had kind of touched base earlier, you had asked about a couple of questions that had come up about, one about whether or not it's okay to use aspirin or ibuprofen or non-steroidal anti-inflammatories. That had come up because not that long ago, I think it was like a French Ministry of Health official had put out on social media caution against using these non-steroidals, but it turns out that that really was not really evidence-based at all. In fact, subsequently, WHO specifically put out recommendations saying that, you know, it's okay to use these non-steroidal anti-inflammatory drugs, assuming that there aren't other, you know, contraindications. So to put it another way, and we discussed this, James, you know, these medications we tend not to use in older patients or sicker patients anyways, because they have side effects that include affecting the kidneys or increasing the risk of bleeding. So we tend not to use them and tend to favor Tylenol. But if you're talking about a young, healthy person who's having muscle aches or a bad headache and wants to take an anti-inflammatory such as ibuprofen, then that's probably okay. The other thing that's come up is that there's some questions that have come up about whether or not for people who are taking blood pressure or heart medications in a class called ACE inhibitors or angiotensin receptor blockers, ARBs, should they continue those, because there was concern that because these medications affect the protein that Vivek had mentioned earlier about the ACE2 receptors on the virus, you know, could taking these medications increase the risk of severe illness? And it turns out that's not the case either. And in fact, all of the major health organizations, including the Heart Association, recommend that for people who are taking these medications called ACE inhibitors or angiotensin receptor blockers, you continue taking them even if you have COVID-19, unless otherwise, you know, told by a physician not to. As far as treatments down the line, certainly the two that are kind of most heavily talked about, one is the remdesivir. It's a nucleotide analog that was developed for Ebola. It didn't really work well for Ebola. It's got some activity against these beta coronaviruses. That was being made available under compassionate use. Now, actually, I believe you have to be enrolled in a clinical trial to have that available. The other one that is probably going to be more widely available, and just kind of, if it hasn't already hit the news in the past day or two, it will, is hydroxychloroquine. It's an anti-malarial and an anti-rheumatic drug that has some antiviral properties. There was a French study. It was very small numbers. I think they had in the upper 30s or 40s, but people who were COVID infected who received hydroxychloroquine, which is an oral medication, had significant reduction in the viral load within 6 days of treatment. And it seemed to translate to also, you know, improved recovery, but it's a small study. It's very preliminary, but I think that's where you'll see a lot more interest and hear about it more. And I believe that I didn't hear the press conference this morning from the White House, but I think that might be the medication that was alluded to. It's not FDA approved for COVID-19. It's FDA approved for rheumatic conditions and things, but that's one that's looks promising at this time.
Right. Anything else to add? Any other pressing questions?
I just wanted to sort of say too that, you know, the coronavirus is the same virus that causes the common cold. And the vast number of people who have had it have been mildly ill and recovered from this virus. We know that people who are vulnerable are the ones that we need to protect. And that's why the social distancing and staying home and heeding the advice. In Hawaii, it gives us an opportunity to reduce the rate of infection, as we saw in that beautiful slide. And that's what we really need to be socially responsible for our elderly, so that we aren't overwhelming our medical system, as has happened in Italy. It's more the rate of infection. We've been dealing with flu. We're used to dealing with flu because it comes very slowly through the year, but it's the rate of infection that is scaring us in the medical field with this virus. And if we can reduce the numbers that are infected in a very short time frame, we'll be able to deal with everyone compassionately.
One thing that my wife wanted to add, I guess recently there's been some publications about, you know, everyone's saying, oh, kids aren't affected, et cetera. But we have to keep in mind that kids under 1 actually are immunocompromised. They don't have all their shots. Their immune systems aren't developed. So still keep in mind, it's not, you know, we saw some rogue people out, their kids hanging out in crowds. It just, you know, just because kids aren't dying from it doesn't mean that they can't, and, I think she just sent me this Hawaii News Now article that just came out, and it says young children, particularly infants, were more vulnerable than older children to COVID-19 infections. Cases in infants less than 1 year old, nearly 11% were severe and critical. So they survived, but they actually didn't do so well. Who knows how that's going to affect their development too. So, any history or anybody else, any of the experts want to kind of comment on maybe coronaviruses in general on kids? I don't know the data on MERS or SARS on kids, but any comments on that?
No, this is Paul Jursek. I know there's been no comment on the effect on pregnant women because they haven't seen the effects, but I echo your comment. Just because you haven't seen it, I think that's still obviously a category of people that we really want to protect.
For sure.
Thank you.
Thanks, Paul. Hi, Vivek. Any information that you might have had on pediatric illnesses and MERS or SARS in the past? I'm just wondering if there was any concerns on that end, and with anything else that maybe we should learn from those infections that maybe we could pass on to this current group.
No, I have not heard anything about that. I don't claim to be expert in the area either.
I know. But I just wanted to see if you had heard just through your channels. I didn't. I looked it up and I couldn't find anything. But I just wanted to see if and Johnny, anything on your end that you could think of for pediatric kind of.
No, not as it relates to SARS or MERS, but certainly I think what we'll find when we kind of as time goes on is that yes, there'll be more infections in children than we had initially suspected, and maybe a lot of these are asymptomatic or mildly symptomatic, so there are also potential spreaders as well, and that's where there's significant public health implications. But yeah, there's so much that's unknown, and it's hard to keep up with. Each day there's kind of new information, but I think when all is said and done, we'll find that kids were certainly affected, but maybe not. A lot of these infections, viral infections, when you look at kind of who's susceptible and who suffers the most effects, it's kind of in this U-shaped curve, right? Where it's like the very young and the very old are most affected. This tends to be more, at least right now, it's looking more like a J-shaped curve where it's really just towards that older spectrum. But who knows, maybe as we get more information and as time goes on and we're able to kind of get a better sense of asymptomatic carriage and asymptomatic infections, we may see that there's a significant percentage of children who are affected, but maybe they just weren't very symptomatic.
Okay, great. Anything else? This is going to be recorded, so if you guys missed the front of it, please feel free to come back and watch. Trying to think of any other questions. I'm going through my little list here. Oh yeah, one question that was out there was obviously, there's these antidotes, or I guess preventive measures like high vitamin C, turmeric, some of these kinds of natural kind of remedies. I'm assuming that they're the same kind of answers, but I just want to see if the experts had any other kind of comments or or just kind of suggestions or references on those.
Yeah, I'll just add that, yeah, there's all sorts of things that you hear that really don't make sense, including breath holding. Like if you hold your breath for so many seconds and you're able to do that, then you're fine. I think whenever there's a lot that we don't know, people can fill in that gap with really bad information. And so just try to stick to reliable sources of information and don't fall for clickbait things on social media or headlines that make you think, hey, maybe that's something. So.
Okay, great. All right. Well, hey, thank you everybody for joining us on this call.
Oh, James, can I just say one thing? Sorry.
No worries, Johnny, please.
This is just kind of more big picture. When all is said and done, I think one of the positives, if you can call it that, of this is actually great practice for the pandemic that will ultimately come. Will be much more severe than this, and maybe more on the scale of the 1918 pandemic. So I think that this is you know, this is a tremendous stress to our system, but hopefully we'll be able to learn from this and really be prepared, because whether it's going to be 8 years from now or 80 years from now, there will be another pandemic, and it will, you know, there are chances that it could be much more lethal. So I think that this is a good opportunity for us to kind of learn the deficiencies in our system at all these different levels, and really hopefully we'll be able to be better prepared for the next one.
All right, one last question here. I think I got it earlier. I just forgot to put it in the comments here. It says here, will it help to use facial oils in order to prevent the virus to attach to the face? Like, just from a kind of a mechanistic approach. What are your thoughts on that, maybe?
No, I'm not, it's really the contact with the mucous membranes, right? Eyes, nose, mouth. So yeah, you'll be well moisturized, but other than that, I'm not sure if there's any benefit.
Yeah, and on top of that, I'm sorry, on top of that, you know, individuals like myself who do sport facial hair, you want to make sure that your mask is able to fit around that if you're going to be in close contact. We've even been, you know, told just to shave it completely. So I think that's my next step over this weekend. But yeah, just making sure that you keep respiratory protections away.
Okay, all right. Well, hey, thank you again, everybody. I know that, you know, a lot of people's meetings are cut short or canceled. There's definitely some fundraisers that are being canceled too. I know there's guidance from Rotary that hopefully things will kind of help from the top also. Lastly, I just want to close with a fundraiser auction item here. If you guys are interested, I'll put a bid up on this online, maybe in about a week if you guys need it. But anyway, just thank you again for joining us here. I'm not sure if we're going to have another online meeting.
James, you are an evil person.
Well, hey, and again, you know, for those of you, thank you again for joining us. This is actually really cool. We actually went through several islands actually joining us here. I appreciate this. If there's any more updates, I'll definitely send them out. And if you guys have any other questions, just email me to them, and I can always send them over to Johnny, Claire, and Chico, obviously. You know, thank you again to our speaker panel. I really appreciate you guys spending the time tonight. And thank you again, Rotarians. I really appreciate you guys being there. And you know, like I said, I just want to close with, again, with this t-shirt. You know, like I said, you know, if we can handle polio, I think we could handle COVID-19. So just keep that in mind, be positive, you know, be mindful. The 4-way test does not apply to the COVID-19 virus. So we need to stamp it out, and we need to use the 4-way test ourselves. So just wanted to close with those comments. If you guys have anything else, please just send me an email, and we'll finish up here. We're kind of about halfway over. So thank you again, everybody. Have a great night.
Thank you.
No, actually, I think the 4-way test does apply to the COVID virus. And if we abide by the 4-way test, we'll beat it.
All right. Hey, Paul, would you like to lead us in the 4-way test?
Oh, lead us in the 4-way test of the things we think, say, or do. Truth.
Is it the truth?
Truth.
Fair.
Is it fair to all?
Goodwill.
We'll build goodwill and better friendships.
Beneficial.
Hey, Rich.
Hey, aloha. Thank you, James, for this great.
James, when you're at Costco tomorrow, can you get me some toilet paper?
Yeah, that's like $30 for the toilet paper.
And a case of Heineken.
I'll take Hey.
Thank you.
Thank you. All right. Hey, aloha.
Aloha.
Oh, I'm signing off.